So thank you very much for the opportunity to speak on real-world heart failure management, global overview. My name is Lars Lund. I'm a professor of medicine and cardiology at the Karolinska in Stockholm, Sweden. And the global epidemiology and the burden of heart failure is very important, as we shall see. This slide shows my disclosures, none of which are related to this presentation. So heart failure, despite good prevention and good treatment, is increasing in prevalence. The worldwide prevalence is at least 64 million. And as you can see on the right, the age standardized heart failure prevalence varies quite widely across countries and is extensively related to lifestyle factors and overweight and obesity. But in all countries, it's a common syndrome and a common cause of hospitalization and a common cause of death. This slide shows the highly variable prevalence in different countries, and it should be interpreted with some caution because of differences in reporting. But as you can see, it's at least 2% in many countries and close to it in others. And I should say that this is in the overall population. There's a lifetime risk of heart failure of 20%. 1 in 5 people will develop heart failure in their lifetime. And there's a prevalence in the population aged 70 and over of nearly 20%. So with an aging population and with better survival after myocardial infarction, better treatment after myocardial infarction, there are many more patients who develop heart failure, who live with heart failure, and who live longer with heart failure. But that also increases the unmet need of implementing heart failure treatment in an ever-growing population. And as I said, this is increasing dramatically over time. This shows the heart failure prevalence currently, or close to currently to the left, 2017, along with the worldwide healthcare expenditures. And as you can see in 2030, this is expected to increase, not only with a high prevalence, but also with significant number of years lost to disability and significant expenses to the healthcare system. Now, there are some variation in the clinical characteristics of heart failure. And this is relevant because we're learning to what we might call phenotype heart failure with better rigor nowadays. So, for example, in North America, there's ischemia and hypertension as common etiologies. In Western Europe, similarly, ischemic etiology. But the proportions of HFpEF, heart failure with preserved ejection fraction, as opposed to with reduced or mildly reduced ejection fraction varies. Ischemia is common in all countries, but heart failure with preserved ejection fraction is less common, for example, in the Mediterranean and African region, Southeast Asia, Eastern Europe. It's more common in North America with the obesity phenotype, and in Central and South America and Western Pacific as well. And the management of heart failure also varies globally, with a high variation in length of stay for a heart failure hospitalization. For example, in North America, where there are incentives to shorten the duration of stay, the mean is 6 days in the hospital. In Western Europe, it's 9 days. And as you can see, it varies also in Eastern Europe, Western Pacific, Mediterranean and Africa, and South America. Very important too, in terms of an unmet need, is the high in-hospital mortality, ranging from a few to several percent, upwards of 5% of patients that are admitted for heart failure die in the hospital during that hospitalization. So heart failure is, despite effective and available therapy, a growing unmet need that really needs our attention in the form of implementation. In the field of implementation science, we can study why medications and other interventions are not implemented and what we can do to raise awareness and to improve use of evidence-based therapy, and as such, also improve outcomes in heart failure worldwide. Thank you very much.